Good evening, everyone. Welcome back to Zero's 2021 Virtual Prostate Cancer Summit. We're so glad you're continuing to join us for all of our exciting sessions. Our next session is sponsored by Blue Earth Diagnostics. We're so excited to discuss imaging and early detection of advanced prostate cancer with this group here. Today I'm joined by Dr. Twardowski, and I have been given permission from the good man to call him Dr. T. So that's what I'll do throughout. His full name is here for you to see, but he's given us permission to do that. So thank you so much, Dr. T. Dr. T is a professor of medical oncology and urologic oncology at St. John's Cancer Center and Providence St. John's Health Center in Santa Monica, California. Also joining us today is prostate cancer survivor and our new good friend, John. So thanks, John, for being here. John resides with his wife in San Diego, and he is living with prostate cancer that has actually recurred. So before we jump in, and we'll give everyone a chance to say hello, I want to run through just quickly how we're going to run this particular session. You'll notice we don't have any slides, so we're just going to have a nice, fun conversation. Really authentic. We want our listeners to be able to hear about everyone's story, John's story, and then Dr. T is going to get a chance to weigh in. We will take some questions from our listeners toward the end. We also are lucky enough to have Jonathan and Tony here from Blue Earth, and Jonathan is our senior medical science liaison, and Tony is the field reimbursement specialist. So they're going to hang tight until the end. Thanks for waving. And then we will have a very awesome group of experts to take our questions at the end of our session. So in addition to Blue Earth's virtual booth, there is actually in our Summit app, they've actually provided a contact link there. If you have any questions that we don't get time to tackle today, then you can ask them at that contact information in the Summit app. Also, you'll find in that Summit app some prescribing information for Oxymin, as well as the patient brochure with, that'll be in the session description in our app. So with that, I will zip it. Let's get started. John, I'm gonna pass it over to you. We would love to just learn more about you and let you share some information about your prostate cancer journey.
Well, hello, everyone, and thank you. I also want to thank Blue Earth Diagnostics, who has arranged for me to be here today to share my story and is compensating me today to share my story and compensating me to do so. As you said, my name is John. I'm 66 years old. I'm going to be 67 in a few weeks. And I live in San Diego with my wife. Two of our children live nearby, and I love San Diego, the weather, and the location. My wife, Jill, and I can go to the coast one day and the mountains or the desert the next. And I'm retired now, but for many years, I worked as a tool machine designer for Hewlett-Packard. I'm fascinated by machines and tools and how they can make our lives easier. In my retirement, I like to go motorcycle rides and with friends, and I go golfing and tinkering in the garage, and I play video games with my daughter and my grandson.
Very cool. Thank you for sharing. So I understand that your diagnosis is not actually the first cancer diagnosis that that your family's been having to face.
Yes, that's right. My wife had breast cancer, and today we are very happy that she is cancer free. In fact, it seems like we had just cleared the hurdles of breast cancer when I received my prostate cancer diagnosis.
Got it. Yeah, that's a lot. That's a lot. Well, we're thinking of you and your family, and we are so excited to hear more about your prostate cancer diagnosis. So tell us, were you experiencing symptoms, or did you just learn of your diagnosis through a regular doctor's appointment and getting your PSA tested?
Well, actually, with everything going on with my wife's treatment, I had skipped a few of my regular annual physicals. So no, this wasn't picked up as a part of a standard screening. I had been out golfing with a friend, and I'm a pretty fit guy, but I was really fatigued as we were rounding the 9th hole. My friend was concerned, and he didn't know me to be short of breath after a few holes. I went to my primary care doctor, who ran some blood tests. He sent me to the urologist, and sure enough, biopsy confirmed that I had prostate cancer. The doctor called to deliver the news on a Saturday, not a day that you want to receive a call from your doctor. I asked how long, and he said reluctantly, so I badgered him. If I didn't get started on treatment right away, then I had about 6 months. What I thought, I'm living life. I'm feeling successful, happy, doing well, and all of a sudden I'm going to die. I didn't want to die.
Right. You're out on the golf course living your life and not feeling like you have anything happening. So so what happened next?
Well, when I received the diagnosis, my doctor started me on pills and injections that suppressed testosterone, and then I received irradiation therapy. My PSA levels dropped significantly after my first round of treatment. So we continued an intermittent approach to checking my levels and adjusting my medication. Somehow my 6-month diagnosis, it's amazing, turned into 7 years, right? I never went into remission, but my PSA levels did go down. Then last year, my PSA levels spiked. My testosterone levels were down, meaning the cancer was feeding on something else. And of course, my anxiety went up at that point.
Right, of course, very, very naturally. So, Dr. Twardowski, we're going to bring you into the conversation. We know that John had a really great response to treatment, but for a short time, and then had a recurrence. So, how typical is this type of? How typical is it to have a recurrence in prostate cancer?
Thank you, Shelby, and thanks, John, for that very eloquent description of your history. So the recurrence of prostate cancer is not that uncommon. And patients who are treated like John with curative intent. So in other words, we are hopeful to potentially cure these patients. Unfortunately, about 30 to 40% of them will recur, will have evidence of recurrence. And that can happen, either after prostate is removed or after, like John had, radiation therapy. Typically, it frankly happens a little bit sooner than he describes, than 7 years. I would say within 5-year period is typical time of recurrence, but it certainly can happen later, like in his case.
Got it. And John mentioned his PSA levels. So Dr. T, can you just chime in a little bit more on PSA levels and how they're evaluated and if they always mean that that's a recurrence?
Right. So PSA, as most of you probably know, stands for prostate-specific antigen. So it's a protein that's produced and secreted by prostate cells, but also prostate cancer cells into the bloodstream. So it's not exquisitely reflective of prostate cancer, because it can also be elevated in normal prostate, especially as you get older and the prostate is enlarging. Nevertheless, it's still very valuable in monitoring patients with known prostate cancer. So for example, if you have your prostate gland removed, if you had prostatectomy, then it's very easy to follow, because there's no source for PSA, normal source of PSA in the body, since the prostate gland was removed. So essentially any detectable PSA level in that setting is highly suggestive of some residual prostate cancer cells. So that's very helpful. In the setting like John, after radiation, it's a little bit more tricky, because prostate gland is still there, so it wasn't completely removed, and it can produce some PSA. So you're really looking at some trends, and as he mentioned, spikes. So if there is a trend and definitive significant rise in PSA over time, and there are some specific guidelines even in terms of numbers, what's the value, that raises suspicion that indeed there is a recurrence, and that typically requires some additional tests to follow up on that.
So what other activities would cause or could cause a PSA to rise?
Well, so for example, after radiation therapy, there's something that's described as PSA bounce. So PSA can be going up and down a little bit, perhaps because of some inflammatory conditions that may be happening in the prostate, or just some essentially inflammation induced by radiation or other causes. But again, usually it's up and down. If you have a persistent upward trend, that typically would raise some red flags that this perhaps is more cancer related.
But a spike in the PSA doesn't always mean that the cancer has.
Exactly, especially post radiation therapy, that there can be these bounces or spikes as you described. So it requires some judgment in evaluating that. But I would say that the trend, multiple rises over time would indicate some potential problem.
Got it. So we know that there are several different types of imaging tests out there that physicians are currently using. So would you mind diving into some of those different types and really highlighting the differences and maybe the pros and cons of those various tests?
Yes. So in the setting where we're suspecting prostate cancer recurrence, additional diagnostic tests usually need to be done, and that can potentially include biopsy. For example, if the prostate is still left in place, that may be subject to biopsy, but imaging tests are very vital in this setting to evaluate the extent, potential for any spread of prostate cancer. And historically, we have used the three major scanning modalities in the prostate cancer setting: bone scan, CAT scan, and MRI. And bone scan, as the name suggests, essentially focuses on bone involvement by various pathologies, including cancer. And it's still valuable, but it has some major limitations. It really doesn't directly show cancer in the bone, but more reaction of the bone to cancer. So that's an indirect reflection of cancer, but it also can be lighting up in the setting of arthritis or trauma. So a lot of potential confounding factors. It also is not very sensitive for prostate cancer detection. The PSA, for example, may need to be as high as double digits, 15 or 20 or above, to really show cancer involvement in the bones. The CAT scan is very valuable, and that focuses predominantly on soft tissues, organs, lymph nodes, also looking at bones to some degree, but it also cannot really detect cancer that is less than, I would say, 5 millimeter in size. So it has some significant limitations in terms of size. MRI uses slightly different technology. It's based on magnetic field and radio waves, and so it has an advantage of not exposing patients to radiation, and it has some real advantages, especially in the setting of bone and nervous system assessment. But patients with some metallic objects in the body, like pacemakers or artificial joints or stents, may not be candidates because of that magnetic field issue. And it's also cumbersome to do, and there are certain areas that are subject to motion artifacts, especially lungs, because MRI takes a long time to acquire. So all of these tests are useful, but have their pros and cons.
Right. Okay, that makes sense. So John, tell us about chatting with your doctor, and when you learned that your PSA level had risen, what did he recommend? What were the next steps for you?
Well, very good. My wife and I met with a doctor to discuss the next steps. And he said that we would most likely need to change up our treatment. So something more aggressive, and something that I would have to take the rest of my life. And that, hit me hard. I wasn't looking forward to that. Once I started, he says it's kind of a permanent thing. When it came to imaging, we asked if there were any other options, and he mentioned, this is the first time, the Psma scan. So that was in 2019. So I was really, interested in that, and so that's where we went.
Good. Well, Dr. T, would you mind telling us a little bit about the Oxymin?
Right. So Axumin, or sometimes also called F18 fluciclovine, was approved by FDA in 2016 for patients who had prior treatment for prostate cancer and now have elevated and rising PSA. So definitely in this exactly the kind of setting where John was found himself. And this is a kind of radio tracer. The Axumin is composed of amino acid derivative called fluciclovine that has affinity for prostate cancer cells, and it's bound to F18, which is the radioactive isotope that emits electrons that can be then captured by a PET scan camera and create image. And it provides, in addition to a kind of anatomical view of the body and where potentially abnormalities may be located, it also reflects the functional abnormalities. So in other words, it only accumulates in the areas that are alive and dividing and metabolically active. So it potentially, for example, distinguish from an old scar abnormality, which is not metabolically active. And in this particular circumstance, the Axumin tracer has affinity for prostate cancer cells and can help to localize and help to tell us the location of the recurrence of disease. And that obviously may have a major therapeutic implications and can guide the therapy going forward.
Okay, great. So how does it work? You know, the day of the scan, the patient shows up in the office, and tell us a little bit about what happens next.
Right. So in terms of practical aspects and kind of logistics of it, the patients show up, at the PET facility. And by the way, the PET camera is a standard camera that is used for other types of PET scans that are maybe in play for other diseases. But what's unique with Axumin is, again, that the contrast, the radio tracer that's injected, and it is indeed injected through the vein, and it really rapidly distributes through the body. So it only takes about 3 to 5 minutes after the injection for the patients to be placed under, on the table, under the PET camera, and the scan takes pictures over approximately 20 to 30 minutes. And there are occasional reactions related to that, particularly at the injection site. You can have a little bit of redness, and there is a small risk of more severe allergic reaction, like anaphylactic reaction, that may require much more aggressive management. And there is also, a little bit of extra, because it's a radioactive compound that's injected to the body, so it does add up to kind of long-term overall radiation exposure for the patient.
Right. So only 3 to 5 minutes after the injection, the patient can then get the scan. And then how long does it take for, someone like you to read the scan? And what happens after that?
Right, exactly. So you're absolutely right. Very quickly after injection, and then again, the camera takes pictures for 20 to 30 minutes. And then, it really depends. I certainly have seen a lot of these scans, so I feel comfortable looking at them myself. But certainly I always rely on expert readouts from trained radiologists. It really, there are some nuances to this, to the interpretation of the scans, and it's critical that, as much as I should and like to look at these pictures, I always consult ultimate interpretation by radiologists, and that that interpretation obviously varies from center to center, but I would say minimum few hours for radiologists to get to it and read it, and that's really critical that you have an expert reader, because these scans can sometimes light up in areas that are not related to prostate cancer. So could be some inflammatory condition or some other condition that may mimic cancer. So it does require somebody with expertise. And also, if the Axumin scan is negative, unfortunately, it still does not completely rule out some presence of very small amount of cancer that is just below the level of detection. It seems that, like with many other scans, there is some relationship between PSA value and the performance of the scan. So in other words, the higher the PSA value, the more likely that you're going to be able to see it. In these very super low PSA values, it's more challenging. That's always important. And in some circumstances, not always, but in some circumstances, it may the findings of the PET scan may require confirmatory biopsy to actually make sure that indeed the abnormality that is seen is truly documented to be related to prostate cancer.
Okay, excellent. And John, is this pretty similar to how you were described all of this information about your next steps in your journey?
Yeah, my doctor talked to me about the potential risks and the benefits of the Psma scan, in addition to the side effects that Dr. T mentioned. And my doctor also noted that there was potential for unusual taste after the injection, which I did. You know, I could taste it in my mouth, which is kind of interesting. It's like, how did it get there? Yeah. Still, I was drawn to the Psma scan because I really thought the cancer had spread. I mean, from talking to him before, I thought it was all over my body. I pictured my body just riddled with cancer. I wanted a scan that could potentially reveal where the cancer was and how big it was. So I wanted to try it, and my doctor agreed that the scan could potentially help us identify the size and location of the cancer and therefore help guide my management plan. I am on Medicare, which covers Psma, and a hospital near me was set up to do the scan. Matter of fact, new equipment. So that was all good news and made the process very easy.
Great. So Dr. T, is there anything that a patient needs to do to prepare for a scan using Psma?
Yeah, so there are some things, not a lot, but there are a couple of things. So one that is relatively unique to this scan that is recommended, like we always talk about how important exercise, right, is for patients with cancer and including prostate cancer. And in this particular case, we recommend not to exercise for 24 hours before scan. And the reason for that, that Psma contrast is based on an amino acid derivative. So what happens after, especially strenuous exercise, that the muscle tissue is regenerating and it's really sucking the amino acids to rebuild its structure. And it may, in fact, absorb the Psma and create a lot of kind of background noise and prevent the tracer to actually go where it's supposed to go. So that's important consideration. No exercise for 24 hours. And then there is kind of a general recommendation not to eat or drink for approximately 4 hours before scan. And you know, just as a reminder that what happens that when you start the whole procedure, the IV is inserted to the vein for the delivery of the contrast, but there's also a little bit of saline that is injected before to make sure that the IV access is appropriate. And then after the Psma is given, again, there a little bit of saline is given just to push it, all the contrast material into the vein. And as I mentioned before, you know, the scan itself, the camera, the acquisition of the images takes about 20 to 30 minutes. And it's important that the patients stay relatively still as much as possible to minimize, you know, the motion artifact. It's okay to breathe, but otherwise, no movement as much as possible.
Sure. And John, tell us a little bit more about your experience and what you found out once you had the Psma scan.
Well, yeah, on the day of the scan, that was in 2019, the whole process took about an hour and a half to start to finish. I had a needle placed in my arm and the doctor came in to administer the Psma injection. I was fine, it didn't hurt, and I didn't experience any side effects during or even after. Then I went into the machine. The actual scan took about 20 minutes, just like Dr. T said. Afterwards, my doctor had me come into the office to see the results. He brought up this color image on his computer screen, and he said out of the whole body, there was a small spot of red on the left side of my groin area, no bigger than a penny. I was honestly prepared to see spots everywhere, but then results were up on the screen, and I was just there, this one spot. And, you say no shots, but I keep that image because it shows that one little red spot and I look at it all the time. So it's cool. It's really cool.
Yeah, well, I mean, what a relief. I mean, just the one spot.
Yeah, it was just amazing. And I tell you, I reached out to Blue Earth. They didn't reach out to me. So I want to be clear. They weren't after me to do this thing. I wanted to, because I am so proud of what we're doing here. I really am.
Yeah, well, we're thrilled you reached out and we all got connected and we're able to share your story. And this is all very exciting stuff. So, any final thoughts, Dr. T, before we start taking some questions from our listeners?
I think that really John's case illustrates the power of kind of new generation imaging that can guide us with more precision directed treatment in selected cases like his. And I think I would just advise the audience to really educate themselves as much about prostate cancer as possible. Obviously for patients, particularly ask for a second opinion if needed. I think second opinion is always good. If your oncologist is offended by it, there's something wrong. We are all used to that, and we think it's very important. So I think it's important to encourage patients to ask questions and stay informed, and that's really very vital for good outcomes.
Yeah, absolutely. I mean, having an empowered patient, it's going to lead to better outcomes. Absolutely. And giving the patient that courage to ask questions and get answers is so important. John, any final words before we take a couple of questions from our listeners?
Well, I'll try to make it quick because I agree with everything Dr. T said. And I would also encourage everyone here to find out more about Axonite. As I mentioned, I was a tool designer. And this is like a tool. I mean, it really is a tool. It helps you figure out what's going on. And I was so confused until I had it done. And then even the doctor said, well, look at this. It changes everything. And I was just crazy when I was ecstatic when I left it.
Right. Yeah. Well, we're thrilled and thrilled that you're willing to share your story. So we'll see how many questions we have. The first question that came in from our audience, and probably Dr. T, I'll have you answer this one, but could you just give us a quick comparison of Oxumin to the PSMA PET that we've heard a lot about recently?
Well, so I think the comparisons in terms of the performance of these tests are still ongoing, but the PSMA PET scan is another new generation PET technology utilizing the same camera, essentially, so the same imaging system, but the contrast material is different. So while, as we mentioned before, Oxumin is kind of an amino acid based compound, the PSMA PET utilizes PSMA, prostate specific membrane antigen amino acid or peptide, amino acid chain peptide that has also affinity to prostate cancer and has also shown very impressive performance in imaging. So both of these PET scan technologies, Oxumin and PSMA, are really changing in many ways how perhaps prostate cancer treatments will be handled or imaging. The logistics are a little bit different. If I remember, with PSMA, you have a little bit longer time after injection. Typically, think about an hour for this to distribute through the body, and then the scan probably takes about the same time, about 20 minutes.
Okay, great. Thank you. And I apologize to our listeners. We only got to the one question. Again, thanks to Blue Earth. Jonathan, Tony, I'm sure you'll get some questions in the app. I want to encourage our listeners to use the app, use that contact section, and you can always reach out to the Zero team and we can help get your questions answered as well. But with that, we need to wrap up. John, thank you so much for being here and sharing your story with our listeners, with the Zero team. Such a pleasure. Dr. T, thank you so much for your time. Thanks for dedicating so much time and energy to this really fun and interesting talk.
Thank you, Shelby and John, and thank you everybody for joining us. It was
Thank you.
Thanks,
Thanks everyone. And with that, don't go anywhere. We have a couple of more presentations that will then wrap up the 2021 Virtual Zero Summit. And if you have any other questions, you need any information on other topics, please visit our website at zerocancer.org.
Bye-bye, guys. Thank you.
Good night.
Bye.